It's Dr. Sabrina Siegel here to introduce a brand new special series brought to you by the NEI podcast. Welcome to the PsychopharmaStahlogy show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The next theme is on practical psychopharmacology. This theme focuses on the brand new book by Dr. Stephen Stahl and Dr. Joseph Goldberg, titled Practical Psychopharmacology, translating findings from evidence-based trials into real-world clinical practice. Dr. Goldberg even joins us in this series. Let's listen in to part 2, Mediators and Moderators in Psychopharmacology, with Dr. Joseph Goldberg.
Hello and welcome to another episode of the PsychopharmaStahlogy podcast from NEI. And this is part 2. And we're going to be talking about mediators and moderators. And this is taken from Dr. Joe Goldberg and Dr. Stahl's new book called Practical Psychopharmacology, translating findings from clinical trials into real-world clinical practice. And with me today, I'm thrilled to have 2 friends and experts in the field, Dr. Joe Goldberg and Dr. Stephen Stahl. Welcome, gentlemen.
Thank you, Andy. Always a pleasure.
Yeah, great to be here.
All right. Let's just jump right in here. I've used the term mediators and moderators. This may be new terminology for a lot of our listeners. Joe, what is the difference between a mediator and a moderator when you're talking about psychopharmacology, and how does that influence treatment response?
So in broad strokes, mediators and moderators are factors that help you predict outcome with treatment. I dare say these are things that most practitioners are facing and confronting without realizing it, or they take it for granted. But this is, in my view, one of the key ways in which you can really up your game as a clinician by being consciously aware of the factors that influence outcome. So a biostatistician colleague at Stanford named Helena Kramer really innovated the work in this area by identifying 2 ways in which factors influence outcome. Factors that are present at baseline, before the patient swallows a pill, before they even walk into your clinic. Baseline factors that could influence outcome, she calls moderators. So these would be things like age, sex, race, chronicity, number of past episodes, left-handed, right-handed, political affiliation. You could think of all kinds of things that might bode better for a certain kind of patient than others. Quick example, lithium tends to work better in certain presentations of bipolar disorder than others. One reason why I like to not say lithium's a gold standard drug is because it's very nonspecific that way. It's an excellent drug in a pure, euphoric, non-mixed, non-rapid cycling, first, second, or third episode patient. Those are all moderators that would enhance the likelihood of lithium's response. So the clinician, whether they realize it or not, in their head is going through a given patient's moderating factors, the kinds I just described, when they are consciously or unconsciously choosing from among treatments. So those are baseline characteristics. They could also include...
Wait a minute. I'm going to interrupt here, okay? There's no such thing as a mediator or moderator. All there is price. And so no matter who you are or what your baseline is, you can't choose a medicine based upon any of the things we're going to talk about this top podcast, right? You just have to give everybody the same thing because it's the tyranny of the median patient. I thought I would just put that in to put a monkey wrench into it and liven up.
The monkey wrench of reality. So this is the key differentiator, or I dare say the mediator, between what you'll call, Steve, bespoke psychopharmacology and the one-size-fits-all approach. So really the question for the clinician is, can we do better than one-size-fits-all?
Knowing these things can help you argue to get the drug you want, correct? Because, these things dictate what your treatment's going to be, and that's part of the problem, is that the payers haven't read our book yet.
No, this is true. Nor do the payers, I think, realize or recognize the relevance of factors like moderators or mediators. They go by diagnoses. And I think, Stephen, in the video you'd made about this book, you so eloquently pointed out that clinicians don't treat large groups of patients, they treat individuals. And the evidence base from which much of this book is written is extrapolation and inference from large groups. So round up several hundred depressed patients or several hundred ADD patients or several hundred anxiety patients and show drug X beats a placebo on a global basis, and then pick the cheapest version of how to do that, and then you're done. And you're right. As a first pass through, that is certainly one way to go at this, is just pick the weaponry that will counteract the ailment without asking questions. The challenge for us CSI or CSNI clinicians is when that approach doesn't work, what do you do? So our suggestion here is dig deeper, or what our colleague Roger McIntyre calls deep phenotype the patient. Don't just go by their diagnosis. Go about identifying all these moderators, because then as you go back to the third parties and say, look, we tried several generics that didn't work. Now when we deep phenotype the patient or characterize their moderators, we might discover a certain kind of patient may do better with a certain kind of drug. And that gets away from diagnosis. But it is a much more nuanced approach, as you well know, than just saying, how do I treat the diagnosis?
For the audience, I'm going to just jump in and clarify something. CNSI is Dr. Stahl's term. You've heard of CSI, crime scene investigator. We're CNSIs, CNS investigators, if you will. So that's one of the themes here of the show. All right. So absolutely, Dr. Stahl, you raise an excellent point. Insurance companies will say, well, today's generics were yesterday's blockbuster brand name drugs. But theoretically, for a new drug to get approved, it's got to have some advance, some benefit, if you will, at least for certain patients. Can you, so you talked about, yeah. The
problem, you're right, Andy, but the problem with that is that you have to show the advantage for the median patient.
Yeah,
so the kinds of patients that get into trials, as Joe says many times, are not the kinds of patients everybody listening to this podcast treats every day.
That is certainly true.
First-line patients with no failures. The idea of being able to demonstrate that in subpopulations has been difficult, and that's really what has led to what we now have is an explosion of treatment-resistant depression, defined as maybe 2 failures of generic drugs. And that group of people has been phenotyped, maybe not too deeply, but phenotyped, and they don't respond to first-line treatments. And so that's one way to phenotype them, and we've done that. And now the payers will pay based upon that. But some of these other mediators and moderators that Joe and I are talking about are not really respected.
So may I offer or recognize, because I think as clinicians articulate these things and we begin to have a dialogue about it, I think we'll encourage our culture as practitioners to invoke this kind of vocabulary. May I give an example? Major depression with anxiety, nasty moderator. Some moderators are predictors of good outcome. We've long known that if you have major depression with prominent anxiety, good luck. Things just don't work as well. The STAR-D studies showed pretty robustly that comorbid anxiety symptoms or syndromes are negative predictors or negative moderators of outcome. So you could canonically cycle through the pharmacopoeia of, do we have 36 antidepressants yet? I'm not sure, but something close to that. If not, you could certainly iteratively go through them diligently, price tag by price tag, or you could look at the literature, which addresses, well, what does work with comorbid anxiety? And in researching the book, I learned so much by working on this book. Turns out one of the better drugs that's been studied when there's baseline anxiety is vilazodone. Thank you, Michael Face, for doing some post hoc analyses showing the presence of comorbid anxiety actually is predictive of a better response in major depression. It is one of the only, if not the only, instances where the baseline moderator of anxiety is actually informative in predicting an advantage to vilazodone. Pretend all else is equal. All else is never equal. But if your anxiously depressed patient comes to you and has failed however many prior treatments, you could arbitrarily cycle through whatever comes next, or you could look at the literature and say, Dr. Theis has taught us that when there's baseline anxiety, this is a drug that stands out. Now, you could then go to make the argument to the third parties, but scientifically speaking, and in your dialogue with your patient, you can stand on evidence-based ground by saying, you have a harder to treat form of this illness, and not all medicines are treated equally, and here's something that has been shown to work better when this condition is present.
You're reminding me, too, about gone but not forgotten. Another class of drugs that seems to work well for that is monoamine oxidase inhibitors, which nobody knows how to prescribe anymore.
Well, actually, interesting, phenelzine actually is converted to a metabolite that makes GABA go up. So the MAO inhibitor that's best is phenelzine, not necessarily trancypramine.
So you'd want to pick that kind of a drug for a certain profile of patient. When you think about it, moderators and mediators, what I was saying at the beginning, are really, I think, what we do without realizing it. So how do you pick who's going to get clozapine? It's not just somebody with schizophrenia. There's a very clear phenotype of a clozapine likely responsive patient. How do you pick lithium? Lithium works really well in a small minority of bipolar patients, but if you happen to have the phenotype characteristics, it suggests itself. You could make the same argument for tricyclics, I would dare say. You could probably make the same argument for just about any class of drugs, whether they're old or new, is a separate issue from what is the breadth of spectrum that's been shown to work for a particular agent.
Well, isn't it Thais that showed that, was it brexpiprazole? But I know some of the atypical antipsychotic augmentations also work in anxious depression.
Mm-hmm. That's right, yeah.
They do. And so here's the rub, is you could say anxious depression is harder to treat. One of the newer drugs may work better than a placebo, but you're still contending with the moderating effect. Calling out an example of a drug where the moderating effect is itself not as substantial is a huge thing. Say the same thing with rapid cycling and bipolar disorder. It tends to put the kibosh on many treatments. I know of none where I could say to the patient, you've had 4 episodes in the last year. Here is the drug to give you because it works better in rapid cycling. All I can say is it doesn't work worser. It still works better than a placebo, but rapid cycling is still a negative moderator of response.
Well, Steve, you brought up something interesting, too, when you're talking about augmentation, like, for instance, with brexpiprazole. Now we're getting into sort of rational polypharmacy and making those more complicated decisions. How do moderators, and let me back up first. I understand what you said about moderators. Mediators, I don't think we've clearly defined yet. Can you just talk a little bit about mediators versus moderators?
Oh, yeah. So real quick. So a moderator is a baseline characteristic, like a demographic feature or a clinical parameter coming into the initiation of treatment. Mediator is something that happens after the treatment has started that can influence outcome. So the obvious things we think about would be non-adherence or adverse effects or comorbidities that occur subsequent to starting the treatment, or the patient gets pregnant, or the patient gets COVID, or something happens along the way that could derail an otherwise efficacious treatment but make it less effective, meaning you have a really good drug, but something comes up along the way that mucks up the response, and we address it differently. There isn't really a pill for non-adherence, but we have to be aware of it. Side effects, we've all been interested in side effects, and so one would be remiss to not say, it's a really good drug for you, it's just the darn side effects make it harder to take. How do we get around that and then try to engage the patient as an ally in a strategy to overcome the negative mediating effects of something like a side effect?
Okay, great. All right, I have a different question. What are relationship confounders and interactions, and can you give us some examples?
Yeah, so this also bears on how we interpret a clinical trial. And one reason why we like to beat up on non-randomized studies is because if you just take a group of people that happen to have been given a certain drug versus another group that happen to not, you can't know cause and effect with as much confidence. That is, if I gave you lithium and you didn't make a suicide attempt, is that because lithium protected you from a suicide attempt, or is that because I cherry-picked all the suicidal people to go on something else than lithium, and so I stacked the deck in favor of my drug? That would be an example of a confounder, a baseline risk factor, a moderator, if you like. So when we interpret studies, when we read studies very critically, we're looking at the methods section to tell ourselves, is this a fairly distributed treatment? If one group was overrepresented compared to the other treatment group in some moderator that influences outcome, then you call a foul and you say, whoa, there was confounding of my indication. So I give this example of suicide because there was a fairly well-known study published some years ago that was a non-randomized study looking at suicide attempts or completions in a big HMO setting with valproate or lithium or carbamazepine. And that very famous study by an esteemed colleague of ours said you're much more likely to try to kill yourself if you're getting not lithium than if you are getting lithium. And the problem is confounding by indication. So there's just no way to know if the treaters selectively avoided lithium in suicidal patients and cherry-picked their patients and gave the lower risk patients lithium. And so this comes up whenever you're picking a drug. An MAOI can be extremely helpful, but if a patient's very impulsive and I'm afraid of their overdose potential, or if they have ischemic heart disease, or if they're on an opiate, those are all essentially confounders. I can't generalize about any and every depressed patient's suitability for an MAOI until I've identified those confounding factors, because that will tell me who got the treatment and are they representative or not. Is that a fair description, would you say?
That sounds very helpful. I'm just sitting here thinking, and I'm realizing we're talking about the limitations of clinical trials and how they don't totally generalize to the real world. Another thing that occurs to me is we have a paucity of clinical trials looking at combinations of therapy. And yet in the real world, as you well know, you've published on this, Joe, the majority of patients are on more than one medication. So how do we interpret the literature to figure that out?
Let me just jump in here and say it's even worse than that, Andy. And that is that usually you study people with one disorder according to DSM, and usually you treat patients with more than one disorder.
That's
in fact,
right.
when you talk about anxiety is not even a symptom of people with that have a different disorder added to their depression. So you have comorbid disorder with two drugs, and there's a lot of that is not known. And in fact, I think, Joe, would it be fair to say that this is why having some idea of moderators and mediators is helpful in the absence of data, because what you're doing is making it up as you go, because there's no guidance from...
Yes, but what I love about what you're implying is it's not random trial and error when you do it that way. So many clinicians, as well as patients, will say, the first drug or two or three didn't work. I guess it's trial and error, isn't it? I'll just try something else. Let it not be trial and error. Let's step back and say, I'm going to steal Roger McIntyre's phrase again. Let's deep phenotype the patient and say something like, there's a history of childhood trauma. There's an early age at onset. There's a family history of bipolar illness. What does that tell me about this particular patient's biology and clinical presentation that might influence my next treatment choice? Maybe I want to try a mood stabilizer. Maybe I want to favor a D2, D3 partial agonist because of their reward-based behaviors. I'm invoking the detective in all of us to get curious and say there's something else going on here. So rather than concretely pick another drug in the category, and since you're right, there isn't a clinical trials database that says we've lined up all the left-handed, metabolically at-risk, hypertensive, diabetic, panic disordered, traumatized, unipolar patients with mixed features. There is no study like that. The best any of us can do, I think, is to take a page from the literature and identify those moderators and mediators so we can say the rationale for picking a particular drug is as follows.
All right, I want to do a little bit of a rapid fire here. I'm going to ask you about specific moderators, and maybe you can tell us a little bit about how they may influence outcomes. So let's start with baseline severity. How does that moderator influence our outcomes?
It's never a good thing to have high severity of illness with any illness, but as a reader of the literature, I know the following. So high baseline severity tends to be a pretty robust suppressor of the placebo effect. So switch back to interpreting the clinical trials literature, and when we say, geez, our SSRIs have small to medium effect sizes, what that means is the placebo effects can overshadow or interfere with picking out a robust effect. If you start out with people with more severe illness, their placebo effects tank. So I'm much more impressed with a study that enrolls high baseline severity patients, because I know the difference from placebo is going to be much more meaningful. The placebo effect is going to be smaller. Doesn't mean the drug is better. It means I can trust the science of the study that much more. And baseline severity is not as if to say you're untreatable. What it means, again, is the non-specific factors that go into outcome. 30-40% of antidepressant response is thought to be composed of placebo effect. So a high baseline severity patient, if they get better with whatever I do, I'm that much more confident that the thing I did is real, and I'm not going to count the placebo effect so substantial. And I can then probably predict for the patient, you are meaningfully better, and while I can't predict the future, I can say the odds are pretty high you're going to stay better because the chance of a placebo response is pretty low. That's one example of severity.
Yeah, so this is a little bit of a paradox. In clinical trials, higher severity predicts greater likelihood of separating from placebo, but in the real world, it predicts harder to treat and worse outcome potentially. You get credit in the real world for the non-specific factors. I always say placebo is my friend in the real world, but it's my enemy in the clinical trial.
Yeah, but because you're right, because some of these other moderators are, if you have high severity, maybe you had more chronicity, maybe you had more early age of onset, maybe you had more episodes, maybe you had more duration of untreated illness, each of which independently are related to severity. And so those things you can't change in the patient who's coming in to see you. You could change it moving forward, though, and make sure that those things don't occur after you interact with the patient. But severity is linked to a lot of other things.
That's a really excellent point, if I could just say, because what you're also pointing out is you can't just check off the box and your MADRS score is over a 30, which is high, or your PHQ-9 is in the 20s, and leave it at that. I know in our busy world as clinicians, this is going to sound like anathema, but to the extent that you can really spend the time going over as many of the pertinent moderators as possible, it's a front-end investment on the treatment. All the things Steve just mentioned, if I know about them on day one with the patient, I'm probably not going to wind up just randomly picking through this drug, this drug, so much as to say, here are the factors that we're up against. And it may not be all drugs. If there's a history of trauma, for example, I may want to recommend a specific kind of psychotherapy. I may want to think about augmentation treatments besides pharmacology, because I know without them, the response is going to be lower. So I want to be prepared, and doing that kind of exhaustive assessment of moderating factors, if nothing else, will give you an impeccable picture of who the patient is from a standpoint of tailoring their treatment.
It also tempers your timing of response, your aggressiveness of treatment, the hospitalization. A lot of things are based upon, you have a very big group of bad moderators. You know, before you're going into treatment, you might be in some trouble, and you try to create a treatment program that can address that.
And wisely, as you just point out, you're also setting expectations in a useful way. So take chronic depression, for example, or what's now called persistent depressive disorder, which used to be chronic major depression and dysthymia. It's now rolled into one. There was some nice work by our friend Alan Schatzberg years ago, which showed if you have what was then called chronic depression, double the time frame for an adequate trial. So that means that if I'm treating somebody with MDD and they're not better in 4 to 6 weeks, but they've been sick for 2 years or longer, that's not an adequate trial. And you don't say on the end of week 6, I guess we're going to switch medicines now. Even in STAR-D, where 80% of the patients, if I remember correctly, had chronic depression, if I'm remembering that correctly, most patients got better after 6 weeks. So there's a real difference between a first or second presentation of depression that's non-chronic from someone who's chronic, because it's going to alter how you tell the patient when they say, how long till I get better? When will this kick in? You say, about 7 to 12 weeks from now is when we're going to judge an effect, because your moderator...
Well, that's interesting. So we've talked about chronicity, but I want to pick up on something Steve mentioned earlier, which is DUI, duration of untreated illness. How does that influence things? And I'm just thinking about the biology of these illnesses are probably progressive if not treated. So
it's on fire when you have a psychiatric symptom. Put it out.
That's right. That's right.
Whether it's inflammation or whatever, there's something bad about having a psychiatric symptom. Sometimes I even call it diabolical learning. What does that mean? It means that the circuit has a certain kind of a steady state. And if you distort it, it says, oh, this is great. Let me keep doing this. And this actually is accompanied by anxiety. So now I like it. I'm going to do more of it. And so you don't want to learn in your circuit to have a psychiatric symptom. And the idea of it really makes me amazed how little urgency there seems to be in the general mental health community about treatment. The brain is literally on fire. If we had things that worked overnight, I suppose we'd get more up in arms about this. But since our treatments take a long time to work, generally speaking, we can relax and say, okay, take it, leave it if you don't want to take it. I also tell my patients that they don't get any credit in heaven, if there is a such thing, for how many symptoms they were able to endure on earth. They don't actually get penalized for they tend to count the number of medicines they're on and how long they're on. But really what you're trying to do is reduce symptoms and not pay any attention to how many medicines you're on. If the symptoms are better, that's what you're trying to do. So you have treated illness, not untreated illness.
Right.
Keeping up with the latest in psychiatry shouldn't be a struggle. SynovianFieldMedical.com is a new website for clinicians where you can find a library of free, hand-selected resources, such as videos and infographics on important psychiatry topics. You can request an educational program for your practice or connect with Synovian medical professionals in your area. Synovian wants to help you get all of your psychiatry questions answered. Go to SynovianFieldMedical.com and explore what Synovian has to offer.
there is some complacency out there. I think there's a lot of good enough is good enough kind of treatment. At least the patient's better. And maybe there's some therapeutic nihilism out there. Oh, there's nothing I can do anyway.
So I don't think that can be our default mode thinking. Mm-hmm. I mean, there are times where you've done everything you can imagine. You've gotten a consultation. You've looked at things 10 different ways. And there are times where you say, medical humility, this is as much as can be done with our current technology. But that's not on the front end. That's on the back end. The duration of untreated illness, I think, in psychopathology is not different from cancer or infectious disease. We don't watch and wait. If the tumor grows, we'll treat it. Nothing good comes from neuroprogression. And if you want to think of known neurodegenerative conditions like schizophrenia or dementias, those are harder to treat conditions at any point in time, but they're even harder as more time has elapsed. In major depression, my ECT colleagues will tell me that please don't make ECT the last thing you think of, because it's not going to work as well. Nothing's going to work as well for the last thing you think of. But how ironic is it that we often save our most potent treatments for too late? Fred Goodwin used to talk about lithium this way. He remarked that the lithium, if it's going to work, its best shot is in the first or second or third round, not the umpteenth. So you hate to think that you're going to ignore duration of untreated illness and save up your best treatments for later. Even clozapine, the more recent findings that suggest that don't wait until you've failed multiple antipsychotics. I'd be curious what you guys think about some of these newer data suggesting clozapine maybe should be a second or third line, not a fourth or fifth or sixth.
Well, it's not, Stardeep taught us anything. It's not what drug, it's where drug. Anything used fourth doesn't work very well. And so you're right. I think Pierre Blier did some studies where they called multiple treatments from the onset of depression, modeling essentially the treatment of HIV or of tuberculosis and many cancer treatments. You don't say, hello, I'm Dr. Stahl, you have ovarian cancer, let me give you one drug, and if that doesn't work, I'll give you two, and then if that doesn't work, give you three. You have a portfolio of drugs, and you hit people with tuberculosis and multiple drugs the first time you see a patient. And so whether it's drugs or mechanisms, I think being more aggressive is what we need to do to make sure that the patient's brain doesn't burn before we have a chance to treat them.
And this goes back to Andy's point earlier about polypharmacy, and let it be, thoughtful. We get that warm feeling as scientists when we look at a regimen where, I can see the receptor complementarity that's going on here. Somebody put together two or three things the way my kids put together a Lego set. Oh, that's really cool. You put this over here and that over there, and it makes perfect sense, as opposed to, oh, you put 5 wheels on one axle. Why'd you do that? And it's lopsided. So we sometimes see polypharmacy regimens in more desperately ill patients that we look at and say, the mechanisms are redundant, or they cancel each other out, or they don't really capitalize, not even on evidence based, just rationale based. So there is a real elegance, I think, that comes from identifying and sizing up a hot brain. It's saying we need to be prepared to go in with heavy artillery, but not random artillery, things that will be complementary and mechanistically synergistic, potentially, and tolerable. And that's really where I think expertise comes in.
Yeah, this is the idea of rational polypharmacy. But Steve's point also it gets back to the point I made earlier. We don't have a lot of trials of combining different medications, and yet in other fields of medicine they do. So again, we're a little bit left without a good evidence base, and we're left a little more to these kinds of issues that we're talking about. Let me get back to a couple of other moderators. How about sex, race, and ethnicity? How would they influence things?
So these are particularly timely issues as we think about human diversity. When we were writing the book, put together a chapter on human diversity almost before it became so topical. And in terms of saying, if somebody with a certain ethnic or racial or geographic heritage comes along, will that tell you anything about drug response? So there's a few things that come up. Certain ethnic or racial or geographically origined individuals will have different response to certain medications. For example, we know in the case of carbamazepine safety in Southeast Asians, there is a genetic vulnerability to developing Stevens-Johnson syndrome. There's a box warning on carbamazepine. You have to do the pharmacogenetic test before you can safely give someone from that part of the world carbamazepine. If you're giving somebody clozapine and they come from either Africa or the Middle East, you do have to be aware of something called benign essential neutropenia. In fact, I think that's in the criteria now, because some people will just biologically be predisposed to neutropenia, and that you have to take into consideration if you're going to give somebody. People with alcohol use disorder will have different activity levels of aldehyde dehydrogenase. And it has been shown that people from Asian descent may have a lower activity variant of that enzyme. And so that makes their capacity to metabolize alcohol somewhat different. So some of these bear on pharmacogenetics or just, let's say, genetic predispositions to metabolizing things. So that's one aspect in which race may play a role. But also some things like sensitivity to certain adverse effects. Metabolic syndrome from second-generation antipsychotics has been shown to be a somewhat higher risk proposition in Latino and African American than white populations. But then we get into mediators like lifestyle and dietary habits and other and access to healthcare. So it gets very thorny. People are very hesitant to go too far out on a limb when talking about racial moderators because of all these other mediators that could come into play. So sex. Women can metabolize certain drugs differently than men. Some drugs have a longer half-life in women than men. Zolpidem's a good example.
Yeah, that's what I was thinking.
Yeah, the reason why the label says give women 5, not 10 of Zolpidem is not sexism in a social sense, because they have a longer half-life. And so 5 is tantamount to 10 in women. Mirtazapine similarly has a longer half-life in women than in men. There was a nice study, post hoc analysis. I guess we'll talk about post hocs in our third podcast about the literature, but in an after the fact analysis of a chronic depression study, it was found that sertraline did better than imipramine in women. And men did better than sertraline. Maybe there are certain drugs that stratify by sex or race. And as we talk about moderators, Steve mentioned inflammation. That's another moderator that may differentiate a tricyclic from an SSRI response. So you put all these things together, age, sex, race, family history, familiality. We should mention lithium. I keep talking about lithium. Has a pretty good concordance. Not all drugs do, but if your first degree relative got better with lithium, that's informative for you. So when you think about creating this bespoke psychopharm, just imagine if you were really checking all the boxes, age, sex, race, family history, chronicity, etc. You could really be an architect and come up with a very well-crafted regimen for a given patient. Whether it's going to work or not is a separate issue, but you can say, I have done everything humanly possible to craft what for you is a tailored regimen based on all your characteristics.
Yeah, I'm thinking here about a couple of other things as well that are related. About chronicity, we've talked about baseline anxiety as a particular moderator. We have, and we touched on childhood trauma, which we all know is a very negative moderator. How about the concept of resilience? How does that factor in?
I love resilience.
Who doesn't?
In fact,
who wants to not be resilient?
What's not to love? Well, what I love about resilience, and we talk about this at some length in the first part of the book, is when you're assessing whether somebody is better or not, you could ask whether their symptom checklists are diminished, and voila, you're better. Or better still, you could ask, when faced with stress and adversity, how do you do? So here I take a page from the cardiologist's playbook. The cardiologist doesn't ask the angina patient, as you're sitting quietly in that chair, do you have any chest pain? No. Good. All right. I guess the drug is working. Off you go. But they put you on a treadmill and they stress you. And as Steve likes to say, I think I've heard him say, life is a stress test. And so I'm much more interested, not just have I lowered your scores on a metric, but rather when faced with stresses and adversities. Resilience is various definitions. The one I like is the ability to withstand stresses without it causing psychopathology. So when bad things happen, when you're under turbulence, we use the analogy in the book of a gyroscope and how airplanes don't flip over when they hit turbulence because the gyroscope keeps them level. Good treatment, whether it's pharmacological or otherwise, ought to help enhance someone's capacity to respond to stress with resilience. That means grit. That means having active coping strategies, the ability to maintain optimism and have access to positive affect. Not just, I'm not suicidal anymore. I mean, that's a start. That's good. That's very good. But rather, so I lost my job and my girlfriend broke up with me. So I went on the interview trail and I got a better job. And I decided maybe it wasn't the right relationship after all. That's resilience. And if treatment, broadly speaking, is efficacious, it will enhance or at least amplify one's capacity for resilience. That's my view on this.
What about excuse me, I was just going to say, there's this interesting study by Hogue, who's a colonel in the Army when we were in the middle of the Iraq War, doing a dose response curve that was very perverse and told us something about resilience. The Army, of course, wants to find resilient people and, if possible, make them resilient. And there's a lot of controversy as to whether resilience is inherited or acquired or both. But in this case, they did a number of Marines that were in firefights. And there's a dose response curve, as you might think. The more firefights, the more PTSD. So up to a point. And interestingly enough, about 10, if you survive 10 firefights without PTSD, it doesn't look like you get it. So you're resilient. And the question would be, pop quiz, how many Marines eventually get PTSD all the way up to 10 firefights and then it levels off? Another way to say it is how many Marines are resilient? And the answer is about 2/3. So about a third of Marines will get PTSD somewhere between 0 and 10 firefights, and the more firefights. And so what's that about resilience? Is this the way they recruited these Marines? Is it the way they trained them? Is it your genetics? Is it your life experiences and epigenetics, essentially, before being recruited? People want to know what that is. So if it's possible, you could layer that on during the treatment or at least use it for prognostication.
Well, certainly there's elements of all of the above, I would argue. But what's interesting is the concept that resilience can be improved, that resilience through treatment is, as Joe said, broadly applied. And that includes, of course, non-pharmacologic treatments. And there are coping skills that can be learned, of course. So I think that we should not neglect this concept of teaching resilience or helping people with resilience, especially once they get better.
Who the people are that have seemed to be, at least anecdotally, the least responsive to psychosocial interventions are people with early childhood adversity. And I think you mentioned that's a very difficult thing to overcome. But there's a such thing called trauma-informed care. And that, of course, can be effective and can be layered onto best psychopharm.
And to your earlier comments about duration of untreated illness, and I think Andy was describing, you form the new normal. So your expectancies start to change for the worse.
Yes.
I think early intervention is not just from a neurobiological perspective, can we offset some of the circuitry that gets rewired with almost a conditioned learning paradigm, but rather before you start to maladapt to failed expectations and why bother and the kind of learned helplessness that occurs, your best chance at amplifying and enhancing one's capacity for resilience is sooner than later. So time is of the essence.
Exactly. Again. All right, let's move on to let's talk about some mediators now. We talked about a lot of moderators. How about pharmacokinetic interactions? How does that impact things?
Far underappreciated, even though I think a lot of clinicians imagine that they're on top of these things. So nobody ever remembers all the P450 interactions, or for that matter, the phase 2 metabolic effects, or things like P-glycoprotein and all the drug-drug interactions, or the biologically innate predispositions to being a poor metabolizer or an ultra-rapid metabolizer, or, hey, how much grapefruit juice do you drink? Right. And broccoli. There's so many things that will go into, or other medicines that you're taking. So what one could devote a lot of time and energy to just thinking through all the drug interactions. I try to remind myself of this as much as I can, because if a patient's reporting an adverse effect or a non-response, or something's not adding up, you should be better and you're not, or you should be having a side effect and you're not, or you're having a weird sounding kind of side effect. I think the first thing we want to do is go back to the meds before we start saying you've got some odd, strange, peculiar ailment, and just ask what could be going on. So I don't think you can ever spend too much time hunting down drug interactions, whether you're doing it through just looking at a Flockert chart, a P450, or using Hippocrates, or whatever your favorite mechanism is. One of the themes in the book is not to say here's the answer, but rather here's how to find the answer. So you get on PubMed, you do some searching, you find, a certain subtype of patient with these moderators may do more poorly than this group. Gee, I have an Ethiopian African patient. Oh my gosh, 29% chance of a poor metabolizer at 2D6. What was I thinking? So it's always fair to ask those questions and hunt them down and research them, because PK interactions can certainly come up and surprise you. And whether you're doing pharmacogenetic testing or not, in a way, to me, that's always affirming what you ought to know anyway. If you're a pharmacologist or wanting to enhance your skills in psychopharmacology, it doesn't mean memorizing all the P450 enzymes, but it does mean having your table handy and looking through the MedX list and saying, is there anything I'm missing here that could be a drug interaction, or that could be accounting for something I wasn't aware of? A lot of alpha-1 binding is this orthostatic hypotension, or redundancy of mechanisms, or pharmacodynamic amplification. Gee, you're awfully sedated. Why are you so sedated?
Yeah.
Are you taking something that's amplifying the effect of something else? You'd hate to miss something like that.
Well, we see at the state hospital, because we do a lot of plasma drug levels, and Meyer and I have even written our own book about that. It's coming out this month, for particularly psychotic patients with antipsychotic treatments. And we find maybe 10 to 15% of the treatment resistance is due to undiscovered pharmacokinetic interactions. And you will have people who have often no side effects and no therapeutic effects. And then that's because they have something funny about the way in which they process the drug. There's also the other thing where I just got a case actually 2 weeks ago sent to me from Iowa of somebody who was on clozapine and died, and looked at the drugs, and they were trying to figure out what might have happened. And they died because they were obtunded and comatose and aspirated and became just basically, and the level at death of clozapine was 8,000.
Oh, goodness. Yeah.
And so I looked at the drugs, and this doctor had put the patient who was on clozapine on 300 milligrams of fluvoxamine.
Oh, goodness. Yeah.
Ouch.
Yeah.
And essentially killed him. And fluvoxamine is a 1A2 inhibitor. Clozapine is a 1A2 substrate. This reminded me of, we'll probably write this up to the literature. We actually looked and didn't see any deaths from clozapine, but it's a good example of what your question was, Andy, about pharmacokinetic interactions. Now, you usually don't see this often, but I saw another case of clozapine who died under very similar circumstances after a woman with clozapine got a urinary tract infection, was given Cipro. And Cipro is also a 1A2 inhibitor. Yeah. And so if you don't really know these things, don't use drug mediator. Part of this story that we're talking about, moderators and mediators, are things like pharmacokinetics. And that's maybe where either blood levels or even pharmacokinetic kinds of genomics, this might be where they're most valuable. And also some of the genomics companies have these drug interaction tables and basically inform you about that. Particularly when you're second, third, fourth, fifth line and the patient doesn't seem to be responding normally, think about pharmacokinetics.
And there are times you can capitalize on these things. So you'd wonder if somebody was thinking, I'm going to intentionally add a teeny dose of fluvoxamine and see if that can raise up a clozapine level. But the problem doing is you can't reliably, just how much that's going to go up. Sometimes you might say to somebody, so I'm going to add bupropion to your SSRI, and bupropion as a 2D6 inhibitor is going to give you a little more bang for your buck with the SSRI. So I'm going to pay careful attention to any side effects from the SSRI. Or sometimes you might add an SSRI to a tricyclic, and then you want to be very vigilant about the tricyclic levels, knowing that a 2D6 inhibitor is going to raise up the tricyclic. So if somebody says, gee, I'm feeling a little funny, you wouldn't want to dismiss that as psychosomatic. You'd want to say, let's check an EKG and get a
how many people say, let's check your blood level, let's check your genomic? Yeah, that should be something that is at least. Now, there's controversy about some of these things because they're expensive and not completely established in practice patterns. But that's when I go to them and get them at that point. But it's pretty rare for people to do that.
This is where apps and software can come in, as Joe mentioned, and be helpful. I think the experience that we've all had, though, unfortunately, is sometimes you get a call from the pharmacy where they have these programs and they give you a warning about two drugs using together, and it's not a clinically relevant warning.
Actually, Andy, that's the reason why this person died on Cipro, is that the database showed so many interactions of clozapine, and that the pharmacists begin to blow them all off because there's 12 interactions with every drug you look up. You're going to call every time and tell about all 12 of them. Yeah. So it trivializes these things. And so after we reported this death, and the database changed in which it highlighted certain interactions like with Cipro, and I think probably will change again with fluvoxamine so that it's more in your face. But a lot of people get jaded about this and say, you hear about stupid interactions. A lot of them really are dumb, and they're not clinically relevant.
But I think wisdom comes from knowing how to manage these things and not just avoid them. I remember when lamotrigine came along and there was a perception, you can't co-prescribe it with divalproex. That's not true. You have to adjust for the drug interaction. That's all. And you have to be mindful of that. And these are ways in which...
The thing that I really get jazzed up about is that if maybe 10 to 15% of the patients I see, either at the state hospital or my own practice, where they're really refractory, can be pharmacokinetically explained and solved. The other ones that can be explained and solved are pharmacodynamic. So the best mediator, Joe, in my opinion, is bad math. What? It's that 1 + 1 = 10. If you get the two drugs pharmacodynamically to get efficacy. As I'm teasing and I'm exaggerating, of course, but that's the secret to a mediator of efficacy that's based upon boosting pharmacodynamic output.
Well, there's a very interesting example, guys, of both a pharmacokinetic and pharmacodynamic interaction. There's a medication from Axome that is bupropion added to dextromethorphan. And you have both the 2D6 inhibition, which gives you a good level of dextromethorphan, but also the pharmacodynamic of mechanisms of actions. So that certainly, you can take advantage of that, as you mentioned.
Hey, that's a twofer, baby, a twofer.
Yeah, that's more than a twofer. All right, let's switch gears. This is a very clinically practical, relevant question. When considering tweaking the dose of a psychotropic medication, what questions need to be asked? What does a clinician need to consider?
So I used to run an inpatient unit. I remember the time where in morning rounds, we'd admitted a manic the night before. And the managed care person at morning rounds said, okay, so when are you going to raise lithium dose? And I said, let's start it first. And then we'll check a level after 5 days. 5 days? He said, yeah, the half-life of lithium is 24 hours. It takes 5 days. 5 days? You have to check a level now, like right after you start it. So I tell this story because we want to avoid, let's call it ridiculous management or pharmacology. It does take pretty much 5 half-lives to get to a steady state concentration. It's probably, in general, there's always exceptions, but in general, it's probably good to let things settle to steady state before you think about tweaking. So I wouldn't necessarily, unless you're on like a titration schedule, like clozapine, you may go up by 25 every so often. Or if you're orally loading to a target dose with divalproex, I want 20 mg per kilo, that kind of thing. That's a titration.
This is an important point, though, Joe, because getting to steady state is critical for tolerability as well. I'm reminded of cariprazine when it first came out. We were told to go up every day, essentially, and that makes absolutely no sense with the half-life of that drug.
Yeah, so I think you want to have a sense of what the aimed for target would be in judging response and adequacy of the trial and whether or not what you're seeing is on a time course for what you'd expect. One theme we mentioned earlier in the book is what I've called the 20% rule, which is you'd like to see a 20% improvement from the baseline in the first couple of weeks of what you started. I like to say if you plant a seed, you don't expect to see a tree after 2 weeks, but you expect to see a little sprout with a leaf on it, and that tells you're in the right direction. So 20% is the metric that's been described in the studies in major depression, in schizophrenia, bipolar depression, that you'd like to see some signs of life. And if you're getting that, you don't necessarily do anything different. You don't tweak. You just nod your head vertically up and down and say, this is good. Let's keep watching. But if you don't see a benchmark like that, the 20% improvement after 2 weeks, then you want to do something. If you hit a next benchmark in a non-chronic patient, let's say 4 to 6 weeks has gone by, I haven't seen an iota of improvement, it's probably time to cut bait, and tweaking is not necessarily going to do much. On the other hand, the more murky area, tell me what you think, but can I fine-tune a partial response? So this is where it often gets gray, and it's important to know what the studies show. So you mentioned cariprazine, for instance. Going past 3 milligrams a day has never been shown to do very much, at least for bipolar depression. So you know what the doses are that work. The probability of seeing just diminishing returns because of more adverse effects pushing a dose higher. Steve's talking about clozapine. If I have a patient with a clozapine, nice good clozapine level over 350 and south of 700, it's like holding a 19 in blackjack. You really don't want to do that. You don't want to go any farther. So knowing those parameters, I'm in the right range. This is pretty much where it's going to net out. I don't want to tweak unless there's a very compelling reason. Someone just added a pharmacokinetic inducer, or you don't want to mistake non-adherence, like patient non-adherence, often underestimated. Patient comes in, they're worse. Oh, let's raise the dose. no, let's make sure they're adherent, because that so often comes into play. So there's often a knee-jerk reaction. You're not doing the let's just raise the dose, rather than the more intensive approach of reviewing, have you been adherent? Are there any drug interactions that are occurring? Are you at the target dose? Is alcohol in the picture? And before tweaking, those are all the things I like to think.
This is a good point, too. Another major distinction between clinical trials and the real world is only certain doses are explored in clinical trials, and those, of course, become the recommended doses. And we all know that there are patients we have to go outside of the range, either higher or lower, from what's, quote, recommended.
And the evidence base helps us here, too. So let's take OCD. For example, there is a literature on using supratherapeutically dosed SSRIs, even beyond the FDA labeling indication for drugs like sertraline or fluoxetine, to go higher than that. So here's an example where you might say to the patient, the family, yourself, and the pharmacist, look, I know sertraline maxes at 200 milligrams a day. Here are some randomized trials looking at 300 milligrams a day, or possibly even higher. You explore the risks and benefits. It's off-label to do that, but it's on evidence insofar as you're saying it's not just a random idea. So that'd be an example of following the literature and the evidence to inform your thinking for that kind of a tweak, even if it goes outside the label.
Yeah, for raising the dose, I can come up with an example, though, for lowering the dose. If you remember the quetiapine literature on bipolar depression, 300 milligrams was the lowest dose they studied, and that became the recommended dose. But we all know from our experience there's many patients who respond, and even an antidepressant response was demonstrated at 150 milligrams. So certainly this is going outside of what's recommended and doing what, again, treating individual patients.
One size fits one.
I always say recommended dose is not required dose. What's required is for you to use your clinical judgment and use all the things we're talking about here to individualize your treatment. All right, we're running out of time. Let me just throw out one quick question, maybe, if we can just quickly address. Why is it so important for clinicians to understand the distinction between moderators and mediators and be aware of their influence on treatment outcomes in the literature?
Steve, you go first.
Some of these are modifiable and some of them are not. It's the main thing I'm thinking of. You can't change your age unless you sit around for a little while, but you can't change your sex usually, and you can't, change your past history of number of episodes and things like that. So the ones that are modifiable and preventing more episodes, for example, in the moderator side, in the mediator side, I would say it's much more interventionalist. The other ones are baked in and tell you what your prognosis is, but often nothing you can do about it except to find out what kind of trouble you're in. But on the mediator side, you can actually do something about making sure that the patient gets better because you can take action. What do you think? Well, how do you define that, Joe?
Yeah, picking up on what you just said, lots of people may come our way with purported treatment resistance when in fact it may be more intolerance or inadequate trials. Not a week goes by where I haven't seen at least a few people where nothing's worked, but in point of fact, a trial gets aborted after just a few days because of something or other that's not a substantial negator of judging response. And so those are mediators. So you put this in language for patients of saying you think that you have this nasty ailment that's just untreatable when in fact it's been hard to finesse and negotiate around side effects or dosing parameters or giving it enough time. The chronic depressed patient who has less than 6 weeks of a trial, for instance, the mediating effect of time. So you can point these things out to patients, and I think that helps to instill hope. People who think that their condition is really out of reach for getting better, you can say, here are all the factors that have mucked up your potential for getting the best effect, and some are addressable. Patients who are intolerant of a drug, maybe it's the generic, let's switch it to the brand, or maybe they're on a PK inhibitor, so let's try a different pathway. So knowing those kinds of mediating factors that will interfere with optimal response can be extremely helpful for maintaining a sense of hope and optimism. And I very much appreciate the way you're describing the moderators. So you're sizing things up for the patient and everybody else and saying, here's what we're up against. So let's make sure we're planning accordingly. If I know that there are certain drugs that have large effect sizes, I think we're going to talk in the third podcast about effect sizes. I don't want to sort of stave off and reserve those just for the bitter end where they're not going to work as well. I want to capitalize on minimizing the duration of untreated illness in somebody who's got high severity and pick a high effect size drug sooner than later because I've got a better chance at trying to thwart their moderators. And if some of the moderators are known to interfere with response, somebody once came or called me to say, could I help them because their antidepressant interferes with their ability to get drunk? And they wanted something that would allow them to continue their alcoholism. It was very turned around. And if somebody's got a glaring comorbidity that's being untreated, we may have to address your alcohol use disorder or your cocaine use disorder in order to make roads in your mood disorder or your anxiety disorder and so on. So we can use these moderators to plan the right treatment. And I think that's critical.
All right, great. Unfortunately, that's all the time we have. I really want to thank you guys for a wonderful discussion. And I want to thank you, the audience, and tell you, please check out the other 2 podcasts in this series, which again comes from Dr. Goldberg and Dr. Stahl's new book, Clinical Psychopharmacology. Today was Mediators and Moderators. Part 1 was placebo and nocebo effects. And Part 3 will be interpreting the literature. Thank you very much. Thanks, guys.
Thank you.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.